right. Welcome back, everyone. Hi, Dr. Williams. Oh, you're still on mute.
I think I did it. There you
There
go.
we go. Okay. All right. Give me a second here. Okay. So welcome back, everyone. I'd like to introduce Dr. Eric Williams. He's a retired vascular surgeon, although he's not really doing retirement very well. And Future of Medicine Advisory Chair. Dr. Williams started the Future of Medicine program well over a decade ago, and we have only grown. So his leadership has made the program possible. So he's going to talk to you a little bit about medicine and the program in general. So welcome, Dr. Williams.
Thank you. Thank you. Hello, everyone. I'm going to try to adjust my screen so that I can actually see some of you, and that may not happen. Meanwhile, we will move forward. So, Sam, are they able to respond? Are their mics on?
Yeah, so if they raise their hand and want to speak, then I can call on
You
them.
will
They can,
control it.
yes, they can also ask questions in the chat and I will read those aloud.
Okay, awesome. So I know that many of you had hoped that you would have been able to get into the in-person segment of of the program. Unfortunately, while that was not possible, we plan to give you as much information as is absolutely possible virtually. The whole point here is for you to be able to say that, yeah, I'm actually still interested in medicine. I'd like to look at that more closely. Or be able to say, no, I know now that this is not a career for me and I'm willing to move on. Either of those choices would be fine. That's why you're here. So don't hold back. If you have questions, absolutely ask, because this is your one chance to ask those sort of things, and be virtually present. We will give you as much as we can to make you feel and see the things that we see through our eyes when we deal with our patients, so that you can feel that you are there and you have a better sense of what we do. Myself, I am a vascular surgeon, but I also do wound care, and I'm certified in wound care management. It's a choice I made because I think the two are very closely linked. And patients who have wounds are at quite a disadvantage. They tend to be ostracized. They tend to be uninvolved in many things simply because of their wounds, which can be painful or smelly, or for which they are embarrassed. Rather than seeking care, they avoid care. And when they do need to go for care, someone has to take them. And in most cases, that someone is also working, is a family member that's otherwise occupied. So it's in all of our best interest to pay attention to patients who have wounds, patients who are at risk to have wounds, and to prevent them as much as possible. And if they do have them, address the things that's causing them, address the associated factors that go along with wounds, such as pain, and get them to heal as much as possible. I'll give you a simple example. It used to be that when patients had wounds, we told them to leave it open and let it dry. We now know that that is absolutely not the thing to do, because the skin cells and the healing occurs from the edges and the base. And if we allow it to dry, those parts of our body, our epithelial cells, can't migrate and close the wound. So that's my little bit about wound. Now I'm going to give you a little history of the future of medicine. We probably started this program back in 2013 with the hopes of giving students like yourself a sense of what medicine was like, so that they could make the decision that you all are now thinking so heavily about. And it's an important decision because it's your career. You're about to embark on a very long journey time-wise, and you are about to take out loans that are quite massive, and you need to know that it's worth it, that it's something you should do. I was fortunate in recognizing, probably when I was about 9, that this is something I wanted to do, but that's not the norm. Little things in your life will push you in one direction or another. And throughout this program, I will say it now and I'll say it later on. As you hear from physicians in different areas, I have two asks of you. It may be more difficult than students who are in person, but I'd like you to make some recommendations, whether it's in vascular surgery, OBGYN, pediatrics, urology, orthopedics, or physical therapy. I'd like you to make at least 2 recommendations that, from your perspective, can make management of those patients better, either faster, more comfortable, or more accepting of the patient or by the patient. And the second one would be, how do you see AI being integrated in that area of healthcare and management? And I ask you all because my experience has been students your age will hear and think of things a little bit differently. You have better management of the tools that are coming than many of us older physicians do. Many of us are good with it, but I think you guys can manipulate it and anticipate it better than we can. So we want to hear from you. And I know Sam is going to ask you for some feedback, so feel free. Really let us know what you think. So as a vascular surgeon, I'm going to try to do something here. I'm in one of my colleagues' office, and I'm going to show you a few things as I sweep around. You see that chair over there, that mattress, and those things that are pillows and scrubs in the corner. Those are some of the things that, as a vascular surgeon, you will have in your office, because you try to get some sleep as much as you can when it's possible. And you are sometimes waiting because the operating room does not have room for you at the time, but the patient needs to be taken care of. So rather than going home at 4 o'clock or 6 o'clock in the afternoon, you stay, and at 9 o'clock, you begin your case that might go on until 12 or 1. That may happen at least once every 2 weeks or once a week. And you need to be prepared to do that for the sake of the patient. Now, what do we cover in vascular surgery? Some of you may know we cover from head to foot. Carotids. The carotid artery is the artery that feeds the brain. There's one on both sides of the neck, and there are 2 vessels at the back. The ones we most frequently operate on are the ones at the side of the neck going to the brain. And we do that to either prevent strokes, or after a stroke has occurred and the patient has largely recovered. We may do it by a longitudinal operation at the side of the neck, or by a puncture wound at the base of the neck that allows us to put a stent in. Various ways. Now, one of the predominant themes you will hear every time we present an operation is that there's a risk. We are doing it to prevent a stroke or enhance recovery, but there is a risk. And when you ask yourself, who accepts the greatest risk of any procedure that a physician performs, it's not the physician, it's the patient. So be cognizant of that when you make recommendations. Put yourself in that patient's place to the extent that you can anticipate what they are concerned about, or answer the questions that might be on the forefront of their mind, and answer it honestly. Because when it comes to treating them, you become partners, but they carry the major risk. We operate on aneurysms. Aneurysms are enlargements of the vessels, typically in the abdomen, but also behind the knee and in the chest, that might come about because of a genetic disposition, that may come about because of injuries. And we have to fix those because as the aneurysm gets bigger and bigger and bigger, the wall gets thinner and thinner, and it's more predisposed to rupture. There are a couple of famous people that I'm sure 90% of you would be familiar with. The older people here will know about Lucille Ball. She was a comedian. The younger ones of you would absolutely know Albert Einstein. He also suffered and died from a ruptured abdominal aortic aneurysm. Unfortunately, it was before we really knew how to manage those. But those are some of the things that we fix, and we can do it through small puncture wounds, which we've been doing for the last 15, 20 years. That came about while I was practicing. In fact, during my fellowship is when we first began to use small grafts and stents through puncture wounds in the groin to replace aneurysms of the aorta in the belly. So we no longer had to make long incisions, and the recovery time was very much reduced, and patients could go home and resume their activity very quickly thereafter. The risk involved in the operation was also reduced. You are familiar with dialysis access patients. Those patients too are involved with vascular surgeons because we've got to provide either a catheter or an access vessel that can be punctured repeatedly every 3 days for that patient to be dialyzed. And again, like everything else, it does carry risk, though much less than others. Bypass procedures for the legs to restore blood flow. And that's even more important in patients who smoke because the smoking tends to cause inflammation in the vessel wall. And that inflammation can cause the vessel to be blocked. And as vascular surgeons, we've got to bypass that blockage so patients no longer have pain in their legs when they walk or wounds in their foot that might require amputations of their legs. And that's particularly true of patients who have diabetes. Diabetes tend to affect smaller vessels below the knee, and those are challenging cases. And you can imagine what that's like in someone who is both diabetic and smokes. Makes for a very, very tough situation. Trying to anticipate some of the questions that you all may have. What's the longest case I've ever done? I would say it's probably been about 12 hours. And then that 12 hours was then extended by another 3 hours. And it's the kind of case that you remember because we don't do that all the time. We don't do that very often. And when we've got cases like that, we tend to do it with a team. Understand that the vascular patient, because they're a vascular patient, they've got conditions that make them somewhat of a higher risk. So they tend to be closely managed with cardiology, anesthesiology, sometimes infectious disease, and internal medicine. And when we are done with them, they then go to the intensive care unit or to the floor where the nurses take care of them. And that too requires a tremendous amount of insight, knowledge, and experience. We can't do any of this alone. We must communicate with each other and work as a team if we want the best outcome for the patient. There are probably some of you here in the audience who are more interested in nursing. Do listen to the physicians. because you will be working with them. But understand that you will also carry a huge responsibility. I know that it was said recently that nursing was not a profession. I absolutely disagree with that. And if that is something you are interested in, keep your head up and keep moving forward with regard to your aspirations to become a nurse. And nursing is for both males and females. The days of female nurses only are long gone. So what I'm going to do at this point is probably stop and find out if you all have questions. Sam?
Yes, we have, let's see, Jillian raised her hand. What is your question?
I had two questions. So my first is, what inspired you to choose the career? Because I know you talked about you had that epiphany when you were 9 years old. And additionally, this profession is incredibly strenuous. So what like motivated you to like think it was worth it? And then my second question was about what you mentioned about risk. Would there be scenarios where you would advise patients that the risk would just not be worth it? And how would you convey the information? Sorry, that's a lot, but those are two questions.
No, those are absolutely reasonable questions. I'll take the first one. When I was 9, I'm from Trinidad, West Indies. And many of you may ask, where in the world is that? And you're probably finding out about many of these countries now that the World Cup is going on. Trinidad is not very far away from Curacao. So if you follow Florida all the way down through Cuba, Jamaica, all the chain of the entire West Indian Islands, the very last one you get to before hitting the coast of Venezuela would be Trinidad and Tobago. When I was growing up, we got to school by the school bus. And we waited at the storefront. And while I was waiting there, an announcement was made on the radio about Dr. Christian Barnard performing the first heart transplant. And as you can imagine, this little kid standing in front of the store wondering, how could you take the heart out of one person, put it into another, and get it started again, and the person lives. And that was my first point of fascination. After that, I used the equivalent of our web at the time. They were called encyclopedias. And I learned as much as I could about medicine and whatever was in it. And I read it voraciously. And that was the beginning of my interest in medicine. I went so far as to take the heart from a chicken which we had killed for dinner. Yes, you actually have to kill chicken sometimes. And I connected it to some batteries that my father had brought home because he was a mechanic at a power plant. And I was able to get that heart started, put it in a glass of water, and it beat for about a minute or so. You can imagine that little kid's fascination when he saw that happen. There was no turning back then. My next key point was probably looking through a microscope and seeing all the little critters that were there that I couldn't see with my bare eyes. There's a fascinating world out there. And I wish I could be in the seat where you guys are now sitting, because there is so much more to come that you all will be discovering. You had asked about risk to the patient and how I present it. Well, I tell them the ratios and the percentages. There was one gentleman I saw, in fact, this morning, who came in to see me because he had difficulty walking and discovered that he had tremendous amount of blockages in the vessels to his leg, starting all the way from his aorta at his belly button. But in his workup, I had listened, and don't use it very often, but here's the stethoscope, use that. Because I detected a noise in his neck, and he had a severe blockage in his carotid artery to his brain. That was about 95%. And what I told him was that he needed to have that taken care of before his legs, or his risk of stroke, which would be much higher while operating on his legs. He wasn't happy with it because his legs was initial focus of his issues. I hope that answers your question.
Yes, it did. Thank you.
You're welcome.
We have a question in the chat. Khan says, hello, Dr. Williams. What is the work-life balance like?
Okay, let's be upfront and honest with this. The work-life balance sometimes depends on society's pressures on you. You know, as I said, sometimes you will find yourself sitting in the office or at work for many hours. I remember one of the things my son used to say to me. I have twins, and when he was probably about 5, 6 years old, one of the statements he would make was, "Daddy, go work." Because I was frequently gone. But you have to decide what's important to you at various times. So having said that, I was fortunate to have the opportunity to be a scout leader. I coached soccer. I coached track and field. I was able to find the time to develop this program that we now find is much more useful and going much further than even I imagined. So you spend the time with your family as much as you can. And as you talk about work-life balance, spend some time with yourself. I walked a lot, I ran, I went to the gym, and during those times, I was able to just go over things within myself to the point where I write poetry. And I enjoy it. I walk, and now that I have my phone, I take photographs. There is a lot of life out there, and there's a way to have all of it. But you have to choose at one point or the other when you're going to shift your priorities.
We have another hand up. Sorry, I don't know how to say your first name. Can you introduce yourself?
It's Shri. I go by Shri.
Okay,
Yeah. And my question was, normally when you're working with your patients, what like age group are they normally in?
Good question. I'm in Florida right now. And my typical age group is anywhere between 70 and 83. In Sacramento, my typical age group was probably anywhere from 50 to 70. The demographics are so different. It really depends on where you work, what the behavior is of the people where you work. Do they smoke a lot? Don't they smoke a lot? What other medical issues do they have? It varies with the demographics. And what sort of patients have access to the health plan that you are involved in?
Does anyone else have any questions? Anyone else? Well, we have about 4 minutes. So Dr. Williams, if you have any sort of final words for the group before we move on to our next speaker.
Okay. So someone asked here, what was the most difficult experience you faced during your education to become a doctor? And there's another that talked about which medical school did I attend. So I'll answer both, and then I do have a message for you all. I attended Howard University in Washington, D.C. I did my fellowship in vascular surgery at Scripps Clinic in San Diego. Now, probably my most difficult experience attending medical school was that I had to repeat my second year in undergrad. There were some particular things going on in my life that up to this day, I never really regarded as being the most stressful, but I understand it was. And it does affect you. My daughter-in-law is thinking about medical school right now, and she's also thinking about um, having a family at some point. Those are two very challenging things to put together. But that failure on my part led me down a road that made me question if this was something I wanted to do. And eventually I said yes, and I did. And it required many hours of study and much work. Now, even during your career, you will be up and functioning and working with patients for many hours. But understand when you're done and you are going home, you will be tired, but you would have done so much good. And I use the term good tired. You will go home, but you will go home good tired because you have made a difference.
All right. Let's see. Is there anything else? We have one last question. I got 2 minutes. What medical school did you attend? Did you answer? And then how many years of education did you go through?
Oh, my. Listen, I came from Trinidad. And as you all can tell right now, things are really tough for immigrants or people on a different visa. I came over here as a student. So to maintain my student visa, I did an undergrad in chemical engineering. I did not get into medical school right away, so I did my master's in civil engineering. So that was another 2 years, followed by 5 years in medical school, 5 years, 6 years in residency, another 2 years in fellowship. So it takes a while. There have been some modifications made since then to medical education so that we can bypass some of these additional years of training. And you guys would benefit from that.
All right. Well, that's all the time we have for now. We're going to move on to our next speaker, but everyone, please thank Dr. Williams for sharing his story and his knowledge and his well wishes for all of you to chase your dreams and achieve your goals. So, Dr. Williams, I believe you're going to join us at the end of the program, the end of next week. And we'll get to talk to you again so you can share with him what you've learned and ask any additional questions there. So thank you for joining us. And I know you have to go back to seeing patients.
Okay, guys, listen, thanks for listening and giving your attention. And don't forget those two ask and really put your questions out there, okay? Take care now.
Dr. Williams?
Yes.
It's Diane Chan from Kaiser. Hello.
Hey, hi.
Hello. I just
hi.
wanted to say hello. And you guys, I hope Dr. Williams mentioned he was the one who started this program at Kaiser. And I just came back from speaking to the in-person cohort. And I know he and I both love interacting with high school folks who are interested in the future of healthcare. So it's wonderful to see you, Dr. Williams.
Thank you.
Oh my goodness.
It's
okay.
Great. Thank you for taking the time to speak to them.
It's my favorite part. Thank you.
Okay.
Thank you.
All right.
Bye-bye.
Great. Okay, well, we'll jump into our next speaker. So Dr. Diane Chan is with Kaiser Permanente. As she mentioned, she's with the Permanente Medical Group at Kaiser. She's a general pediatrician. She's the chief of physician health and wellness and the chief of investing in our people department. So please welcome Dr. Chan.
Hi, you guys. I'm so excited to see you. I am unfortunately having some technical difficulties, so you might have to bear with me on this. My mouse decided to not work, so I'm going to try. If not, Sam, I'm going to email you my 2 slide decks, and then I'm going to have you run it, okay?
Perfect. No problem at all.
Well, so my 2 topics that I'm going to spend with you guys this morning is about taking just a overview of the path into becoming a physician. And my second half will be about pediatrics, the specialty, the job, the role. With that in mind, and while I am trying to pull up my slide deck, would you guys please just share with me what you are considering in the world of healthcare? Sam, do you want to call on people or have them rotate? But I'm going to go off camera for just a second.
No problem. And they're putting it in the chat, so I'll read it off. So we have pediatrics, pediatric GI, dermatology, neurosurgeon, allergy, oh my goodness, cardiology, pharmacy, psychiatry, anesthesiology, CRNA, dermatology, radiology, neurology, neuroscience, pediatrics, primary care, anesthesiology, physician assistant, pharmacy, neurosurgery, pediatrics, radiology, respiratory therapy, cardiology. So
I love
a
it.
lot.
I love it. Psychiatry, they keep coming in. Podiatry, amazing. Okay. I'm going to say a couple of comments. Let me just give you some context of who I am and where my comments are coming from. I am by training a general pediatrician here at TPMG, which is the Permanente Medical Group. I work at Kaiser Permanente, which is our clinics and hospitals. I have been in this role. I've been doing this for longer than you guys have been on Earth. So I'm starting my 25th year here. I am also a mom of 3 daughters who are in the thick of things. So one of them is pre-med, and she just finished up her junior year at Stanford. The other, I have twins who are 19 who just finished up their first year at UCLA and Berkeley. I spent a whole lot of time training to get where I am today. And part of my many roles here at Kaiser, Sam said it, but I know it was just very many words that may not mean a lot of things to you guys. So I'm going to spend a moment talking about that. So I am the chief of investing in our people. What does that mean? And I want you to listen to these. And I know Dr. Williams gave you some beautiful comments as well. And like I said, I have young adult kids who were teens at one point, who were younger than teens at one point. And we know sometimes when adults speak, it sort of goes way over your head, or you're like, okay, that sounded cheesy or whatever. But I really want you to file this into your, I don't know, lots of brain cells are being used right now for other things. I get that, but we hope to impart some pearls that you'll take with you throughout your training journey, okay? One of them, so the investing in our people, once you're ready to get a job, consider getting a job with Kaiser Permanente in the sense of, I truly do think it's one of the best places to work. And it's because we have teams like investing in our people. What does that mean to you? I'm trying to think of it from your high school perspective. Think of your guidance counselor, your academic counselor, okay? That person helping you decide on classes or where to apply for college. And think of your therapy counselor. I don't know if all schools will have them, but like a mental health therapist counselor, that person. And then think of perhaps your nutritionist, your PE teacher, your coach, lots of teachers who are there to support you. Like, that's what the team is about, is knowing that healthcare, any role in healthcare, like Dr. Williams was alluding to, is hard. Really, you can't do it alone, and you need people to be there to support you in whatever way that may mean to you. So that's what our team is for. Okay, so so that's where I come from, in making sure that you go through this training journey with knowledge, with support, with resources. So I think I applaud all of you for 2 things. One, for deciding to at least right now consider a career in healthcare. Okay. It's not an easy place to be. Sometimes the training journey is long and difficult and physically tolling and emotionally grinding, like what Dr. William was saying, like the good tired. And or especially now, if you're following sort of the political climate, not everybody believes in science anymore. Okay, which coming from me, a scientist, a clinician, that's a hard statement to take when people are doubtful of what you're saying and doing. So again, I applaud you for considering a career in medicine. Two, I've done this for several years now in terms of interacting with SSVMS folks, and I'm very impressed that you guys all have fields or specialties that you're throwing out that you're interested in. Super, super cool. For those of you who don't know, and I love who somebody put, I am interested in radiology. I love that because it shows that you're interested, but it feels like you could be talked into something else, right? Like I want you to go into it. Yes, you want to do neurosurgery. Please have an open mind. I would almost bet tons of money that if we met in 5 years on the same Zoom in June of 2031, that your specialties and your jobs and your path will have changed. So allow that to happen. Like if you're suddenly super interested in something else, allow that to happen, okay? Promise me you'll just go into it thinking, yeah, Pete, psychiatry, but just when someone just, a topic or a mentor or an attending suddenly like says something that you're like, oh my gosh, that's amazing. That's beautiful, okay? So allow for that. Crossing fingers, I'm going to try to share. Otherwise, you don't want to look at me all the time. So let's see. Okay, we're going to do, here we go. You know what? Hang on. Now, my first talk is going to be about the career path to becoming a physician. So for those of you not considering this, I hope you can still take some pearls out of this in the sense of words that you'll hear on campus or at your work. Okay, are you seeing something different now? It says, what are you talking about?
Yeah.
Perfect. Okay. So the goal of the next 20 minutes or so is really to familiarize you guys with, like I said, the path into becoming a physician and sort of lots of words that often is thrown around. And in some of the lectures and talks that you'll be hearing from other physicians or healthcare professionals, like what those words mean, okay? So I hope this is valuable for you in that way. So next slide talks about members of the health, and please, same with Dr. Williams's talk, put in the chat any questions that you have, and Sam, I might need you to help me with that since now I can't see any of the chat with the screens that I have set up.
Yeah.
Okay, so physician, I've thrown that around, and that's synonymous with doctor. MD is your medical degree. DO, does anybody know what that means? Anything into the chat? It's osteopathic medicine, so doctor of osteopathy. Generalist is also can be called, do you guys know words like PCP? So primary care physician. Or generalist means a family medicine doctor, internal medicine doctor, pediatrician. So we are generalists in that we train and learn about various topics, various organ systems in the body. A lot of the specialists, which I'll talk about in a second, they specialize or focus on specific body parts. Okay, so head and neck, ear, nose, and throat. You guys have heard those specialties, right? Even like neurosurgery, the word neuro is in there, so it implies it's about neurology or the brain. Okay, so so generalists are not. So we're tasked with learning in general. That's where the name comes from, about most of the body functions and organs. And so that's usually our first line of someone saying, I don't feel good. They go to see the generalist. Does that make sense? And then And then the specialists are the ones who then will focus in on a specific organ part. Like I said, head and neck surgery is the head and neck, ear, nose, and throat, or pulmonologist is the lungs. Okay, so then you further hone in on that. Then we have lots of other licensed staff members who will help and be part of the healthcare team for a patient. NP, what is that? Throw that into the chat.
All right, we got our first nurse practitioner.
Perfect. Amazing. Nurse practitioner, you're right. How about PA? Physician assistant. Nice. And so you get the idea. MA, I work intimately with a MA, medical assistant, RN, registered nurse, and LVN. Does anybody know what that stands for? Oh, very nice. Thank you. So as you can see, well, you guys are well versed in this. Very good. So as you can see, it's often like literally more than the doctor who is part of the team, and very much so in terms of the different ways that the whole team works together to assist the patient. Okay, you guys are already doing so well. I'm going to just throw out more terms, okay? So again, on medical school is obviously the time you spent after some undergraduate education to further your studies in medicine, okay? So how many years is medical school? Okay, yes, you're right, you guys. It's sort of a trick question. Who was it who says here? I'm trying to. Jin said usually 4. Do you feel comfortable coming off coming off of mute to tell me what that means?
Yeah, so usually the curriculum takes 4 years, but people have their own lives, right? You're living while you're in medical school, so some things that come up in life could make it last a little bit longer.
Ah, very good. Okay, very good. That is definitely true. Like what Dr. Williams says, yeah, life stresses, things happen. So for example, some of my medical school classmates got married and had a baby. And as you can imagine, that takes some time out of your ability to go to class or go to do your rotation. So yes, it took a little bit longer for them. The reason that this is a trick question is that medical schools now, traditionally, they were 4 years. And like what Jin said, curricula-wise, it's 4 years. However, there are different nuances to that. You guys are rising seniors, is that right?
Some rising juniors as well.
Some are juniors as well. Okay, so if you're thinking of applying to college usually is 4 years. Again, people can do it in 3, people can do it in 5. Again, that's after, usually 4. And then after that, you go to medical school. However, there are now, and I'm sure have you guys heard of the sort of the the combined programs, which is a straight MD program, college and medical school together. Have you guys heard of that? Yeah, I'm seeing some nods. Yeah, there are going to be some programs. Let's see in the chat. Okay, yes. Okay, so yeah, there are some programs that are 7 years. So you apply once when you're applying into college, and then once you get into that program, you're straight through. I know University of Rochester has that, and other schools will have that, where you essentially get into medical college and medical school at the same time. Okay, and then there are some medical schools that are less than the 4 years. Some are now 3. So UC Davis is a fantastic example. It's called their ACE program, and they are geared for folks who are interested in a career in primary care. And so they are supported and have lots of resources to do medical school in 3 years, with the goal of then you becoming a primary care physician. meaning you can't be a surgeon, you can't be a dermatologist. You've already signed up to becoming the generalist I was talking about on the prior slide. Does that make sense? Okay. So internship. Does anybody? So internship, and on the right side of the slide, you see intern, right? What does that mean? Do you know what that means? If you watch Grey's Anatomy, you might know what that means. Yes, you're a first-year resident. So residency is many years, and for some reason, the first year they get their special name. It's like freshman, basically. So during the first year, that's your internship, and you're called an intern. Then the other years of your residency, which is the training that you received in that field that you've chosen after medical school, you're a resident. Sometimes names are thrown into that, like the junior resident or the senior resident or the chief resident, all descriptions for the resident. I think that's a bit too much for us to need to know right now, but that's what that means. Throw out some ideas of how long residencies are. And in particular, if you've already put in like you want to be a neurosurgery, or if you want to be something in medicine, psychiatry, do you know how long your residency training is? Throw that into the chat if you do. Depends on specialty. Yep, absolutely true. Whoever said peds people, do you know how long your residency is? Very nice. Okay, it looks like you guys have looked into this, is what I imagine. 3 to 7 years, 4 for yeah. So it's many years, right? Like the idea is generalists are usually less time in training. Neurosurgery, yeah, you're operating on that like 1 centimeter thing in the brain. I would imagine you have to spend a long time learning how to do that well. So yeah, you guys get the idea. Good. Fellowship, what is that? Extra specialized training. You're right. So you're honing in now on another field. So it gets more and more specific. Perfect. So it's after residency, like Hazel was saying in the chat. So I'll give you an example. One of my med school. So I went to undergrad at Stanford. I went to NYU for medical school. And while I was at medical school at NYU, one of my classmates did her residency in general surgery. Then she did a fellowship in plastic surgery. And then she decided she wanted to specialize in hand surgery. So we were joking that she's forever like in training. So I've been doing this for 25 years. She literally, I think, started practicing 10 years ago. So can you see it gets very, very, very specific, and you're in training for a long time just to learn those skills. Gap years. What is a gap year? Does anybody know? Or between what and what? It's when you take a year off. Okay, good. Yes, usually it's that year between college and medical school where you have a gap in your training and you're either doing something else. Sometimes it's taking a break, like it's what it could be a break, but a lot of times it's either just a moment to sort of pause and decide, am I on the right path? Is this what I still want to do? Or before I get locked in, should I do something else? Jen, I really appreciate your question about whether or not I took any gap years. The answer is yes. And that's exactly the scenario that I was just talking about. I'm from the East Coast. I don't know I don't know if that's relevant, but I went to college at Stanford. I was thinking of pre-med, and then I did a summer at the NIH, the National Institutes of Health. I guess that's relevant because, East Coast folks, it's right in Maryland, so it would make sense that I would spend my summer back home on that side of the world, and I got really interested in research. So after college, instead of applying straight to medical school, I thought, oh my gosh, do I want to do science instead? Do I want to do benchtop research? Do I want to become a scientist? Do I want to be a researcher? Or do I want to do an MD, PhD? You guys have heard of that, right? You go to medical school and you're doing research at the same time. So I was confused with all those opportunities. So I took a year where I was a fellow at the NIH doing research and just to see which path I would take. Ultimately, I decided medicine was for me because I love people interactions. So when you're in a lab, it's a very different world. The excitement comes from the cells. The excitement comes from the animals that you're testing. It comes from that. I looked at lifestyle, and I think you guys should also sort of think about that too. My fellow scientists and fellows, they were living on they were basically applying for grants all the time. Grants are money that you get from usually the government or a company, something to fund your research. And so they would write these grants and apply for them and sort of like live on the edge of like, will my work be able to continue? And then they would get sort of their letter of like, yes, you were given $3 million, or instead of the 5 you were asking, you were only getting 2. I just felt like with my personality, I couldn't do that. Like I couldn't live with uncertainty. Does that make sense? So I didn't pursue research for a lot of reasons. And those were the 2 main ones. What do people do in gap years? It really depends, a wide variety of things. It depends on where that gap year is, if it's between college and med school and fellowship. It depends on what kind of skills you have, like, or if your goal is to develop more skills or just take a break, like do a sabbatical and you were a comp sci major and you decided, hey, I'm going to join a startup and use other parts of my brain for a year. How can you do medical school and research at the same time? Sorry, I wasn't in med school yet. I was about to apply to, I graduated from college. I was applying to medical school and I was thinking, should I apply to MD school? Should I apply to MD, PhD school, or should I apply to graduate school? So I wasn't in anything. Does that make sense? What did I major in college? I was very boring, unfortunately. I started out as an econ major. I started out as a math major, and I realized quickly that math at Stanford was a whole different league than like calc in high school, AP Calc. And so I quickly was recognized that I could not be a great math major. So I did econ. I did other things for a while. And long story short, by the time I needed to pick a major, biology was the only thing that I could my classes could fit into, and I could graduate in 4 years because I did some exploration of other things just to while I was doing pre-med. Oh, I see what you mean. MD, PhD. Thank you for clarifying. So MD, PhD, it's a long part. It's about 7 to 8 years. So you're not in med school and doing research at the same time. It's often staggered. So usually they are my classmates did 2 years of medical school. The first 2 years were usually classroom with us. And then when we started our rotations, our clinicals, they went to their labs like full time for 2-3 years. And then they joined us, not us, but another group that was coming in to do rotations years later. Does that make sense? I'm going to pause. I'm going to go back to your questions. I promise. I just want to get to attending physician. That's a last word on the glossary here. An attending is who you become when you're done with training and you get your job. Then you're an attending. It's usually not, it's used in situations where there are other trainers with you, meaning at Kaiser when we or not at Kaiser, in private practice, right? When it's just the office, like the dermatologist, their office manager, you're not really an attending, like you are, but attending implies there are fellows around you or residents around you, that there's this hierarchy and you're the attending. Okay, so okay, the road to becoming, and I'll just do this really quickly, you've got to take your MCAT, which is your admission test into medical school. And then while you're in medical school, you take boards, which are steps 1, 2, and 3. I'm going to go over a day in the life. So you might hear other presenters talk about their typical day. Pre-rounds, well, rounds, do we know what that means? You might, again, on these medical shows, but it's when the whole team meets together and they go around the ward to check on patients that were there over a night and seeing how they did, okay? Usually the job of the intern or the resident is to pre-round, to gather the information, check in on patients before the rounds with the whole team so that you're ready to speak on about the patient when the attending is in the room, right? Got that? Consultations or consults is when we need help from our specialist. So a patient is now peeing blood, hematuria. Well, what does that mean? So the generalist will only know so much about that, and then we will then rely on a nephrologist, our renal specialist, and we'll send them a consult, ask them for a consultation to our patient. Okay. Inpatient is when you are literally like the patients who have to stay overnight in the hospital on the ward. Same thing, same words, inpatient ward. The flip side of that is outpatient. So in the clinic, like if you guys are going in for your checkup so that you can be cleared to play football or get your, vaccines, that's all in the clinic or in the outpatient or the offices. You'll hear words like that. ICUs, intensive care units. There are very many of them. They're definitely where the sicker patients are. So you can add a letter in front of the ICU to then describe the where or who you're caring for. So can anybody think of any other ICUs? Throw that into the chat. Oh, NICU. That's neonatology. So these are for the preemie babies or really sick newborn infants. Anybody else? Any other letters? If you put a P in front of it, PICU, pediatric ICU. There is surgical ICU, M medical, MICU, medical ICU. So lots of ICUs depending on the patients. Very good, you guys. Very good. And then I think my last slide talks about specialties. Oops, I don't know why this is here. So I think we've already talked about this before. Just want to make sure the same words, like words that mean the same thing. It's like synonyms. Internal medicine, medicine. IM is also like if you ask somebody like, what was your residency in? And they might say IM, that's internal medicine. Family medicine, family med, AFM, adult family medicine, again, same thing. OBGYN, obstetrics and gynecology. We talked about, so usually in many parts of the world, it's ENT, ear, nose, and throat. At Kaiser, it's HNS, head, neck surgery. Interventional, that's a word that you can throw into a specialty. It implies that they do procedures. So interventional radiology, those are the folks who might do exams or screening, imaging on patients that require some type of procedure. Interventional cardiology, again, same thing. They will do a cath, a cardiac cath. And EM, ER, ED is emergency medicine, emergency. It's basically the doctors who are in the ERs or the emergency department. Okay, I think that's my last slide. I hope that was helpful. Any questions on this, sort of the general medical speak before we launch into pediatrics? I think, let me scroll up. There was a question that I didn't answer. Oh, I think it was about loans. Did you need to make loans during university and how much effort was required to pay it off? Fantastic question. Yes, I did have loans. And part of the reason for my gap year, do you remember I said I was doing research as an NIH fellow? Part of that reason too, I said I needed to see which which path to pursue. I also needed to replenish my financial fund. So I was paid to be a fellow, not hugely, but some. So I got many thousands that then I put towards medical school. NYU, where I went to medical school, was the first school in the country that made tuition, that paid tuition for everyone. I don't think you guys remember that, but I remember that. And I was like, oh my gosh, I wish that had happened when I was there, but it didn't. And I totally recognize that finances are a burden. I hope by the time that you guys get there, more and more schools are becoming free. So NYU is an example. I know our Kaiser Medical School in Pasadena is free for the first four classes. It's a fairly new school. For the first 4 classes, tuition is free. Not sure if it will be extended, but my point is I hope other schools, so that everyone, regardless of your personal economic situation, that you'll be able to attend medical school if that is your dream. Anything else? Okay, then this might be a good transition time. I'm going to come off camera for a sec so I can pull up my next slides. There we go. I did not take out any loans during, I did take out loans during undergrad. It was a small amount, and I was able to work while I was in school to be able to pay that off. Okay, transitioning to pediatrics. Can you see my my ped slides now?
Yeah.
Great. My chat, Sam, my chat screen is now gone, so I'm going to rely on you for that.
Okay.
All right. Hang on. Give me 2 seconds. My screen is okay. So I live in the world of pediatrics, which I hope most of you are familiar with in the sense of, can you throw into the chat if you have a pediatrician or if you see a family medicine doctor as your primary care physician? Which one? Pediatrician? No, yeah, pediatrician or family or someone else. Family medicine, cool. So perfect. So I'm hearing mostly pediatrician and a few family medicine. Wonderful. Are any of you Kaiser patients? In the past, I've seen a few patients of mine pop on to these. Perfect. Okay. Okay, so let me tell you about my world because I don't think I would trade my job for very many things in life. So I'm a general pediatrician. I work here in Roseville. I've been here forever, like I was saying. My next slide is really, well, it probably belongs in the other talk in the sense of how do you decide on a specialty? It feels like many of you have already done that. And like I was saying, still be open, okay? And if you don't know, please don't feel like you're behind the game because many of your peers have already put into the chat what they want to do. It is, I would say it should be more normal at this point in your life that you have no idea. Or like you're like, I want to do medicine probably. Because I really, unless you've shadowed, which is an awesome opportunity that you'll have in the sense of as you, if you hear that somebody's dad is a pulmonologist or somebody's aunt is a physical therapist, be brave and ask, hey, can I see what you do? Can I follow you around at work one day? And they might say no, but that's okay. But these are the ways that one of the ways that you can find out what it's truly like. Okay, so in general, we think of it in 3 categories: medicine, surgery, or psychiatry, meaning these are the big 3 groups. Like medicine are all the things that I talked about in terms of family medicine, emergency medicine, pediatrics, pause on OBGYN for a sec, but that the medicine ones are like pulmonology, endocrinology, genetics, all of those things are just what we categorize as medicine. Surgery are the straight like general surgery, neurosurgery. My husband is a urologist. So though plastic surgery, a lot of the surgery fields. And then there are some that are both. So OBGYN, right? Those are the folks who see patients in clinic, but they also operate. So they'll do C-sections, they'll do other female reproductive organ surgery. So a lot of some will overlap. And then psychiatry, a whole other world, right? Mental health, therapists, managing medications. So that's, are you still seeing my slide? You are? Okay, I am no longer seeing my slide. I don't know why. Okay. Okay. Then another way to decide what you want to do. Let's say you're like, I have no idea. Decide, or as you hear these different presenters, listen to where they work, if that's compatible for what you want to do. Clinic, like I said, medical office buildings, you're seeing patients. Those are the ones that you walk into, like when you go see a pediatrician, right? Versus hospital. I don't know if any of you had needed surgery, maybe your appendix was getting inflamed and had to be removed, but that's the hospital setting. And those are the folks who are rounding, right? Who are checking on patients who've stayed overnight. Are you the type who needs specific work days? Like you're like, I know I work on Monday, Tuesday, half of Wednesday, all of Thursday, and half of Friday. Like that's my work schedule. It's going to be very rare that they're going to need me for work on Wednesday afternoon or Friday afternoon. So I know that was beautiful because I knew I could take my kids to ballet class or swim practice during those days, right? So I needed predictability. Some of my peers don't need that and they rather do shifts. So their schedule comes out a month in advance, and hospital-based medicine, HBS or ER, emergency medicine, you get scheduled days or nights and then a month in advance. That personally would drive me crazy because like I said, I need to know, can I take them to swim practice at 4 on Tuesdays? But if you're like, no, I love it. I love working 3 shifts and then I'm off for 4 days. Perfect. Then consider a specialty that is more that way. Does that make sense? It really depends on how, like, don't get into a specialty and suddenly realize, like, wait, what? I have to work a weekend. So that's, how do you decide on clinic versus hospital setting? That's a great question. It's really sort of what you, it's a lot of, so with that, I'm answering the question, the difference between clinic and hospital setting, right? So there are many ways to go about that. I would say clinic, sometimes that the patients are less sick. They're not coming in when they need like major surgery. So you're seeing more stable patients. You have a longer interaction with them. Hospital setting, it's sort of like what they need, right? They come in because they sprained their ankle. You're fixing their ankle and then out the door they go. Or they're coming in for a specific surgery, or they're really sick and they just need to hang out with you for a while as you're fixing whatever issue is going on. Their blood sugar is too high, their sodium is too low. So I think the way that you decide is sort of, what is your personality? Are you like always on the go, like you need to see sick people, or like sometimes not so sick people is great too? Like when I see patients for checkups, like that's great. We're chatting to make sure, like, are you eating vegetables? Are you drinking enough water? So it's a lot to do with the pace. I talked about work days and level patient interaction. I think I just said that in answering your question, right? So each specialty will come with different patient interaction amounts, meaning I interact with patients all day. I'm in there talking to the patient, to the parent, to their sibling who came along with them. And there's lots of exchange of information and interaction. Then my radiology, a good friend of mine is a radiologist, and she always says, I would die if I had to talk to patients as much as you did. Totally fine. Like she sits in her cubby and she reads films. And so she talks to no one. So again, based on your personality, and I'm exaggerating, of course she talks to someone, but just, do you see sort of the differences? And the same thing, if you're going into pathology, if you're going to psychiatry, it's like how much patient interaction there is and how much do you enjoy. And duration of patient relationships, that's a good one too. I see patients, I'm so lucky to see patients, babies who are like 50 hours old. And then I also see patients who are ready to go to college, who I've seen for years, and they're saying their goodbye to me before college, and we're doing their last checkup. So they're like 18. So I have a long relationship with my patients. And the ER doctor who saw the kid with a sprained ankle, who fixes them up and they're out the door, may not see that patient ever again. Both are great depending on which one are you leaning toward, right? Which one are you looking for? Which one fits? And like I said, it's all about a fit for your personality. Any questions before I leave this slide? You guys have been so interactive. I really appreciate that. So now in the first talk, I talked about the training journey in general. This is what it is for pediatrics. After high school has 12 grades, undergraduate. Again, there are going to be exceptions, like somebody pointed out. It could be shorter, or if you go in with tons of AP credits, you could be done in college in 2.5 years, 3 years. But in general, 4 years, 4 years of medical school, unless you do that fancy 7-year combined program or something different. Residency for pediatrics is 3 years. And then if you decide to specialize pediatric pulmonology or pediatric cardiology, it's more. Okay. Does that make sense? Okay. So what is pediatrics? Like I just said, it's 50-hour-old babies, newborns, new to earth, to like you guys, to you all. Okay. And so I love that because it's not, people think, oh, peds is peds. It's not. I think I'm a specialist, really, even though I'm a generalist, right? And I say that facetiously, but you know, medicine is very different. Talking about a cough, or a fever in a 50-hour-old versus a cough in a 18-year-old, and everything in between. There's just some diseases that you might hear of, like you know, asthma is one of those where every age group can have, but laryngomalacia is something that babies usually have and teens usually don't. Hand, foot, and mouth disease, infection for little people, usually not in bigger kids. So it's sort of learning about things in each of those age groups that makes pediatrics sometimes difficult, but very, very, like for me, I find it academically very challenging and stimulating in a good way. I'm a general pediatrician. I work in an office. So on my schedule are checkups, urgent visits. So whether they fell off a monkey bar or they have had a fever or a tummy ache. I also do procedures. They include toenail excisions, putting in a Nexplanon contraceptive device, circumcisions on newborns. So things like procedures, taking off a wart, draining an abscess, procedures that can come into the office. I also really, you know, look at the whole person. So medical, social, emotional, sort of that all feeds into one another, right? Like if you're tired, is it because you're depressed or is it because you're not eating enough? I'm going to give you my typical day. So after you guys, I start seeing patients at 1:30, and it looks like a pretty exciting one for me in the sense of I have a good mix this afternoon of office patients, people who are here in the exam rooms to be seen. There's also a lot of telemedicine now, phone appointments, video appointments. Parents who felt like either they didn't think it was that their kids were sick enough to be brought into the office, or they're busy. Like one patient recently, they were in Disneyland and they had a question because a rash appeared. So they couldn't come see me. They were still at Disneyland in Anaheim, so they booked a video appointment. There are also many hybrids of that. Some of my colleagues no longer see any office patients, so they just do work remotely and they do telemedicine aspect, which gives them the flexibility, or if they have young kids, then they are working essentially from home. What am I doing during the day? I'm seeing patients, I'm charting, although lots of AI is helping me with that. So that's been super cool. I respond to patient emails. I respond when a parent is calling. I also look at lab results. So maybe I did a lab test on Friday. It's now in my inbox now. I have to look at it, decide what to do. In fact, I know one patient is waiting, lab is waiting for me because they now have thyroid disease. So I'm going to be calling the parent back in a little bit. If I need further help for that thyroid disease, I will be calling my endocrinologist and asking them what to do if I have questions beyond what I already know how to do. I attend meetings. Some of those are educational, meaning, you know, something that a cardiologist will give us a talk so that we can better manage patients with murmurs. I also then just on my own will read articles or learn, you know, other things that have changed. Like we no longer use this medicine, we'll use this medicine. So that's a lot of my day. This is sort of just to give you an aspect of the many things that come into my day. I love it. This is, no 2 day or no 2 even hour is the same, right? Like I said, I see the newborns, I see an injury, I see this is you guys, 18-year-olds who need vaccines and paperwork for college. So along with all the different categories, you get the idea of the different roles that I play. 15-year-old who's sexually active but parents don't know. Yikes. That's a different one than the ear infection or the hand, foot, and mouth, right? 4-year-old with trouble breathing after eating cashews. Then we're worried about food allergy, ADHD. So lots of different things. So I am super excited always to see what my schedule looks like. Do you prefer doing in-person or telemedicine visits? They're very, very different. I would say I love the in-person ones because that's where I develop my relationships. And plus I am super excited genuinely to see them back. For my healthy patients, they don't come in very often. I see them once a year, once every 2 years. I want to catch up with them. They were telling me they were trying out for softball. I want to know how did it go? Are you still playing? How did it, was it exciting to travel to Colorado for your tournament? Like I, as a person, want to know them as a person, and it's easier to connect in the office. Telemedicine is a whole other set of skills. You're trying to see through the camera, which is sometimes you can't see everything that you do. When you go see your pediatrician, they're observing you the minute you walk into the exam room. I mean, not to make you nervous, right? But like they are, and we get an idea of just how you're feeling, what your mood is. Can you really move that ankle well? Are you still limping? And with a camera just in that box, it's really hard to tell all of that, right? Or is that wiggly kid really with ADHD, or is he just normal? But now like mom is making him sit next to her, so you can't see what he would normally do. But in the office, I can see in a 20-minute visit, he's going crazy. He's like tearing up all the exam paper. So I think you learn more in an in-person visit. But I also love the flexibility of telemedicine. A lot of times I get to do it at home and my kids are around, my dog is around. So there are benefits of that too. A set schedule, a healthier work-life balance. I'm going to come back to that. AI Help You Chart. We have a program that you guys have heard of scribes, right? A lot of people will become a scribe. So that's an actual person in the exam room with a doctor and a patient. And while the doctor is talking to the patient, the scribe is typing our note, like typing down what has been said and spoken. So we don't have physical scribes. We have a program that we have on our phones that we will bring into a room with the permission of our patient. They're listening. The AI software is listening. So when I come back, let's just say a note is created for me that then I go and edit to make sure it speaks like me and that it has the information that I feel is important. So thankfully, you still need the human aspect of it. So much of the charting is done. I just have to go edit instead of like writing the whole note on my own. Residency in pediatrics. Help me out with this question. Here, let me bring it to what does residency typically look for someone in? So it's 3 years. Can you come on, Mike, and elaborate?
Yeah, hi. So
Hi.
I was just a little bit confused, like, for residency, like where would like a person interested in pediatrics be like put into? Because like, for example, I've seen like some people be put into like emergency medicine, but they're not sure of like what specialty they want to go into. So, like, would a person interested in pediatrics like specifically be put into like a clinic?
Wait, so at the point of residency, you've already decided you're gonna do pediatrics. There's no like you're not sure. Is that what you mean?
Yeah.
So medical school is when you're deciding. Then you, the 3rd or 4th year of medical school, you're applying for your residency. You are then locked in, at least for now, of what path you're choosing. Like I'm applying for dermatology. I'm applying for pediatrics, and then you're applying to a specific hospital with their program of residency. But you're right. Some of my residency months time were spent in things that you wouldn't think of that was in pediatrics, meaning I did spend time in emergency room. I did spend time in like a sports medicine clinic, but that's to learn all the things so that, again, when my patient comes in with a sprained ankle, I would know the things I learned in sports med of what to do, or emergency medicine, what to do. So you're learning towards your specialty that you've already decided. Great question. Thanks for letting me elaborate. Okay, my last slide, I believe, is just recognizing that whatever you go into, if it's peds or even something else, you're taking on many different roles. Okay, I am, of course, first and foremost, a clinician. I'm teaching, counseling parents and kids about how to use the inhaler, what asthma means. I'm often a therapist. Remember that 15-year-old sexually active kid whose parents don't know, and now she has an STI, has gonorrhea, and now what do we do? So, of course, I'm a clinician who's going to treat that, but I'm also the therapist of like, okay, now what? Like, that's a lot to go by, to deal with on your own. Now what? I'm also listening. I'm listening to a lot of medical facts and medical history from the parents, but also listening in general. Sometimes medicine is the listening, right? I see, remember that 50-hour-old baby that I see? Well, it belongs to parents who are exhausted because the baby hasn't slept. So I'm listening. I'm providing therapy by listening. I'm an advocate. Lots of times parents want everything done. They're like, so-and-so doesn't eat any vegetables. Can you check labs to make sure they're okay? I don't know if you guys hear that, but I hear that daily. And, sometimes it's my job to say, you know what, so-and-so doesn't need a painful medical procedure. They need this, or how about this? So even though we, for the very many years, will interact more with the parents rather than the patient, we are advocating for you, the patient, the child. We recognize that sometimes you may not know how to speak. Like when you're 2, you can't speak for yourself, or even when you're 14, you don't know how to speak for yourself. And we are here taking on that role for you. And on the flip side, I like to think of myself as a cheerleader. Like I get so excited. So in the fall, I talk to my 17, 18-year-old patients about where they're applying. And then in the spring, when they come back and tell me, I am super proud of you, I'm super excited for you. So, and just big things and little things where they tried out for softball, made the team, or didn't make the team. Like I am there to cheer for you as well. This is, again, putting in a plug for Kaiser Permanente and my email address if you have any follow-up questions about pediatrics, and that's me on our website that we have for our members. Okay, so that is a quick tour through pediatrics. Any questions, any things that you thought like, oh, I didn't know that, or like, I thought that was true, but it's not?
You can raise your hand or put it in the chat.
Ah, interesting. So, can you expand on that? Can you come off mute and expand on that for me?
Hi, yes. So what I mean is that I think some specialties are harder to get matched into. Some have like a lower acceptance rate, and I was just wondering like how that whole process works.
Yeah, that's a great question. So the whole match is way complicated, and I wish I knew the answers, but I don't. At that point, it's going to depend on your performance, much like anything else that you're applying to, right? Like right now you're applying into college, right? They're going to look at letters of reference. They're going to look at your transcript. They're going to look at your extracurricular activities. So that's similar, and then an interview. So that's similar to how that match, part of the match process. So it's called match because you're looking at the school and the school is looking at you, and you both mutually put in a list of rank the schools that you want to be at, and the schools rank the candidates that they want, and it's sort of cross-referenced. But yeah, there are ones that are super harder to get into, and then there are ones that are known to be easier. But I wish I would know like the secret sauce of the formula, but I don't. And usually most folks are matched into the residency of their choice into the special. If not, there is a process to get you there. It might pause for a year or two, but you'll end up usually where you want to go. Jillian's hand is up.
How can you find like, because I feel like for me, I'd be more interested in like clinical over being in the hospital. How can you like find like, do different clinics, like, will they specialize in certain specialties as well? Does that make sense?
So you're saying, what are your opportunities to learn about specialties?
No, because if
No.
I'd want to do like a certain specialty, could I still do it like in a clinic?
You're saying down the road.
Yeah.
Like if you become a pulmonologist, can you work in clinic and not a
Yeah,
hospital?
because I'm interested in neurology, but I wouldn't want to do it in the hospital because I feel like that environment wouldn't be for me.
Perfect. So in general, to answer her question, but in general, I know that medicine now is becoming, fortunately for you guys, many of the jobs is something that you can shape it into, or that they're already offered. So meaning your example of neurology, but not in a hospital. So then you're looking for purely outpatient neurology offices, and they absolutely exist. In the same way that like pediatricians are now hybrid, or we can work sometime in the hospital and sometime in clinic, or sometime in clinic and sometime in telemedicine. So and a job in Montana is going to be very different from a job in New York City. So I think there are going to be very many opportunities for you to be able to shape or find the job that fits for you, and may not be perfect, may not be the first job that you do, but there's definitely the ability. Sam, do we have time for one more question from Miriam?
Yes.
Okay, Miriam.
Yeah, I was just wondering, like, how would you describe your work-life balance on like the daily?
Yes, somebody asked that before. So I know that's a hot topic, and I love how you're asking each. I think you asked Dr. Williams that as well. I don't think of it as a balance implies a seesaw that stays level. I don't see it that way. I've done this for too long to recognize that sometimes it's not a balance. I think of it as more of a priority. When am I giving priority to who and to what at the same time? My daughter, who's at home, she's studying for MCAT. She just texted me with some questions, and I just said to her, honey, I would love to be able to respond, but I'm about to do a meeting and I have patients later today. So again, I'm not balancing, like I can't do both things at once. So it's prioritizing. And so I'm not sensing that her questions were urgent. So I said, hold on, let me deal with this first. So I think so I love that question. I think you'll have to find it for yourself, but it's the same idea that you can't do your strength training and calculus at the same time. So if you've calculus a test tomorrow, maybe tonight you're spending it more on calculus, and the strength training will be a quick 5-minute upper body. You know what I mean? So it's not that you're doing everything at once. So the balance comes from you deciding what to prioritize, and then sort of what is important to you at any given time. But yes, I feel like now in my, maybe you asked me that when the kids were 3 and 5 years old, my life was overwhelming. And even then the priorities were different, right? Like I felt like I needed to spend time with my kids over work. So I would adjust my work schedule differently than now that they're off to college. So it's a constant game, and I don't think it's perfect. The good news is people around you don't expect it to be perfect. I heard a really good quote, and I'm going to leave you with this. There's a new quote that somebody shared with me. You know, all the balls that you feel like you're throwing up in the air, right? Whether it's school, it's friends, it's exercise, applying to college. Some of those, your job is to find out which of those are glass and which are plastic. So you can drop plastic balls, glass balls will shatter. So know what's important to you at that time and throw up the glass ones and catch them. And some of the plastic ones will be bouncy and you can find them another time.
All right. Well, everyone, please say thank you to Dr. Chan. Thank you very much for that overview of your specialty and the career in general. You gave us a really good foundation for all of the folks we're going to hear from over the next 2 weeks. So
Perfect.
I thank you so much for your time. And before we go, I'm going to do a drawing today, even though we weren't going to start till tomorrow. I'm going to do a drawing today. And the drawing winner is Emmy Burmeister. And so I'll send you a $5 gift card. Thank you all for being on. I will send you an email. Check your email every day. I'll send you an email in the next few hours. The recording will be available as well. And we'll do this again tomorrow. Same Zoom link. Thank you all for being on. Have a good afternoon.